So we'll start with one here about modafinil. So this one says, with respect to modafinil, is it just for the treatment of daytime tiredness, or is it also for general fatigue and patient drive and desire to live? So I think Chris might start on that, and I might chip in at times.
Okay, so modafinil, as David Hilton-Jones said, is a psychostimulant, and it stimulates the brain to stay awake, and that's primarily what trial data has shown to be its benefit. So the primary indication for modafinil is to keep you awake and not to treat fatigue or motivational problems. Having said that, a lot of us have suspicions that modafinil may not just keep patients awake, stop them falling asleep, but may actually improve fatigue levels and even motivational issues. But that has not been well studied. It wouldn't be, we couldn't use that as an indication, say with a pharmacist or with your doctor. We couldn't write that, but it may be a good bystander effect that hasn't been well studied. So if you do have problems with falling off to sleep, then certainly modafinil is a good tablet to try, and it may have the unintended consequences improving your generalized fatigue and motivation. But those two later aspects are not well studied.
And then, related, we have what level of daytime sleepiness is classified as excessive, and at what point would modafinil be prescribed? So I'll just start off with that one. And in a way, I think doctors often do this. I would often perhaps throw that question back to whoever's asking about it, whether something is excessive. So there's sort of two answers as to whether something is excessive. One is that we could look at whether we've got any way to measure it, and we might actually say that above a certain point we'd say something is excessive. And in a way we can do that with something like sleepiness. I wouldn't be surprised if a few of you have filled in the Epworth sleepiness score, where you're asked lots of questions about whether you might fall asleep in various conditions, like sitting watching telly, or sitting reading, or sitting talking to somebody. So we can do things like using that scale to define whether something's excessive. But on the other hand, it's also a very sort of subjective thing. Us saying that's excessive is only because that's a judgment made by somebody else, by some scientists really. And often people who are on the borderline, perhaps if you were just one below the cut-off mark, you might actually say your sleepiness was excessive. So that leads us on to the second bit, is excessive is actually what affects you often. So what is a lot to one person may not be to another. And a lot of what we try to treat with myotonic dystrophy and other conditions is we actually look at what's causing a problem for people. If something is causing a problem for you, that's when we would think about whether we could do something about it. And whether you call that excessive or whether you say it's causing a problem, it depends what words you want to use. So, for instance, if we're looking at modafinil, we might, if sleep is causing people a problem, they really think that it's, say, making it difficult for them to work, or it's making it difficult for them to look after their children, or meaning that they aren't getting up and out and doing things because they're falling asleep. Then you might think about, or have a talk about whether we want to prescribe it. On top of that, with modafinil, it can be a bit difficult because of what we heard earlier in the day, is that we are quite restricted now in whether we can prescribe it or not, because there's been some quite strict guidance that's come out with regard to some of the safety considerations around modafinil. Don't know if you want to. active at it all.
Yeah, I mean, there are safety considerations around modafinil, a theoretical risk of a severe skin reaction, but I'm not even sure if that's been reported in the UK. I think it was reported in European studies. I perhaps had one patient who's had major cognitive thinking problems on modafinil, and then it was a situation where you could have predicted it potentially. So in general, it's well tolerated. In terms of daytime sleepiness, I think there's two aspects of it, and doctors are good at looking at how patients fall asleep during the day inappropriately when you shouldn't be falling asleep. But there's the other side. There's the number of hours slept at night time, and some of you, I suspect, could sleep 12, 14 plus hours during the night, and clinicians haven't even contemplated what to do about that. So I say to relatives, well, can you use an alarm clock? Can you motivate them? And they say, well, why don't you come and try? So if we're to be honest, I don't know what that's. So that's hyper somnolence. That's sleeping too much when you're meant to be sleeping. I'm not sure. How do you treat hypersomnolence of that type, as opposed to falling asleep during the day, Margaret?
Well,
is there a treatment?
I'm not sure if there is a treatment, but what I do is actually, basically, I'd say to somebody that we know that people with myotonic dystrophy tend to need to sleep longer than other people, and partly it's often actually people's families knowing that and working around it is important as well, because then you can allow that little bit more time for people to sleep without it perhaps causing some of that conflict that it might have caused otherwise. And I suppose the other way I perhaps would more treat it perhaps is that people's sleeping pattern can sometimes shift over time, and people can go to bed later and later at night, even right into the early hours, and then get up later and later in the morning. And that's where I probably would want to intervene and try to shift someone's sleeping pattern back so that they do actually make themselves get up in the day, try not to have naps in the day, try to then go to bed at a reasonable time. But the only way to shift that sleeping pattern back more towards other people's sleeping pattern is actually to start getting up that bit earlier. So that's where it can become difficult.
Margaret, can I make just a quick comment that made me smile? Chris just mentioned about waking people up. About 3 weeks ago, I had the experience of the carer of my son, ringing me saying, Margaret, I can't get into the flat to see Peter. And so I went to the flat and we telephoned and we rang the bell and we banged on the door and we couldn't wake him up. And of course you stood there thinking, is he dead or not? You know. And so after half an hour of this activity, we sent for the police, and they came with that big red thing that you see on the television, and they banged the door, and they broke the door down, and then Peter wandered up the corridor. But he was all right.
So perhaps we'll move on from sleep and tiredness. I think we'll go over a bit more towards the scientific side of things. David, do you want to read your question?
So the question here is, what is the science behind the degenerative effect of myotonic dystrophy? And I think that there's a few points to make really. The first is, well, what's actually happening in the condition? Well, we know that this repeat expansion transcript in the nucleus appears to be sequestering other things, that other proteins in the cell that should be used for other purposes. And that's obviously a chronic effect that happens over a long period of time. And so what's probably happening is that there's some subtle dysfunction of lots of cellular components, and it's almost like that threshold effect before you start to have a seriously negative effect on the muscle. So if you compare to, say, Duchenne muscular dystrophy, where the dystrophin gene is affected, and it's known how that functions in the cell membrane, and therefore muscles start to deteriorate. We don't have that clear picture in myotonic dystrophy. So we think we know what's happening, where there's a series of sort of things going wrong, but we can't be absolutely sure. There's a lot of variation in the natural population in terms of muscle strength. We're not all Olympic athletes for sure. So it's natural that there will be a... Wait again. So it's natural that in a condition there's a range. Now, one possibility, of course, is that we know that, as somebody mentioned already, that in different tissues of the body we see that the repeat expansion is different lengths. And we know that over time, studies on the white blood cells, the length of the repeat in white blood cells, that actually increases. So that in patients there is this further complication that not only is the repeat having an effect, but it's actually getting a bit bigger, so therefore the effect will be worsening over time. So that is at least part of the complicated picture. So not a clean answer, but I think that's an approximate summary of what's happening.
I mean, neurodegeneration and myodegeneration, degeneration of muscle and nerves, is really a holy grail in science, isn't it? And we're approaching some understanding. And actually, myotonic dystrophy, we understand more about that degenerative process than most degenerative diseases, I'd say. But in muscle disease, and it's still, there's a few proteins linked to altered splicing, but we don't understand the sequence of events yet. But
this question to Mark, so you can be looking at it while we go on to the next one. So just a bit of pre-digestion for you, Mark. So we've got one now about the registry. So I think it's quite important to, it's really good that we've had the registry over the last year, and thank you again to people who've started to enter into it. Now this is a very important question actually. It's saying that about, with the registry, there's a requirement for the person with myotonic dystrophy to input it. It is a requirement for the person with myotonic dystrophy to input their own details. More severely affected people can't do this, therefore they can't take part in the registry. And B, the registry, that means the registry can't have more severely affected people on it. So that's a very useful thing to bring up. With the myotonic dystrophy registry, of course, it's yourself, a patient who decides to enter the details and consents to enter those details into the registry. You can actually get someone to help you put it in. It doesn't mean that you have to actually physically use the keyboard and use a computer to do it. If you trust another person enough to sit beside you and help you with putting those details in, you can do that. And so that does allow more severely affected people who perhaps have problems with their hands to enter details into it. The other thing is, just a slight aside from that in a way, there actually are quite a lot of ways in which you can adapt a computer and a keyboard to work without being able to use a conventional keyboard or a conventional mouse. And that's the sort of thing you could ask when you go to the muscle clinic, or perhaps if you see an occupational therapist separately, is how you can actually control a computer. But we certainly would want people who are quite severely affected to be entering themselves onto the registry or finding someone to help.
We're really keen for patients, even if you can't enter data, just reiterate that, to register it into the registry. I don't know whether, is Libby? Yeah. Have you got something to say, Libby?
I agree exactly with what Margaret said. If sort of physically you can't control the computer, that shouldn't in any way stop you from registering. Somebody else can certainly be clicking the buttons. That's not a problem at all. We still want you to sign up.
And maybe the paper aspects of the registry, is that proving difficult? So in other words, filling in forms rather than computers?
If you don't have a computer, if you don't have access to the internet, we can send you out paper forms. We have them ready. We would still encourage you to use the online system if you have access to it. It's easier and more accurate for everybody. But if you just don't, that's fine. You just need to contact me and I'll send you out paper copies.
Right, now I think Mark should have had perhaps chaps have a look at this. If you want to read your question out first, Mark.
I think it's more of a statement than anything else, but there is a question in here as well. So somebody has, either themselves or a relative, a 3-year-old with a severe form of congenital muscular myotonic dystrophy with difficulty walking, is, and then in quotations, statement, close quotes, appropriate stroke usual, if so, any source of help advice. I don't think any of us on the platform are the best people to answer this question, because this really would be much better answered by a paediatric neurologist or a general paediatrician or community paediatrician. But the short answer is the whole idea of statementing children is that they should get extra resources and extra help, which is really necessary for them to be able to get help at school, help in the community, basically. So, is it a good idea? If this question is simply asking, is it a good idea or appropriate to be statemented? That's the sort of the technical term. Then I would certainly say yes, because it's the best way. It's almost like a passport to getting a whole host and range of treatments, access to OT, to physios, to all sorts of things. So I can see somebody nodding in the front row. Do you want to pass a comment? Can you wait for a mic?
We had the same situation with our daughter Amy. She was in a mainstream school. Found it very difficult to do the schooling sort of thing. So I can recommend that you really push ahead, but it's very difficult to do. But once you get that support, it's the best thing you've ever done with her.
Yeah, and I guess what you're sort of intimating there is that the children who are maybe less severely affected, who are in mainstream schools, then actually having a statement actually means they get lots of extra personal help as a result of it.
Yes. Yeah.
So can I just add a comment to that as well?
One thing I was going to say is that both my children were statemented, and it's amazing once they've got a statement and, for want of a better word, label, how many doors actually open for you. When they're just told they've got learning difficulties, forget about it. They've got myotonic dystrophy, half the people don't know what you're talking about, but the doors actually open for you, and you actually get what you actually need eventually. But it's a hell of a lot of work filling in forms, I'll tell you that. You have to keep going.
When I was in school, I went to public school, okay, and I was actually statemented, okay? And I got a lot of help. I was in special needs classes. They actually made me with some of my French class and actually gave me special needs classes, okay? Which actually helped me a lot. So, like I was saying, if you get statemented, then it's pretty good because it helps the kids a lot. And it happened with me, and it was really helpful. Even though it was a public school, and I might be behind some of my friends, it does help you a lot because they might take you out for like some French classes, which, yeah, exactly, you're right.
Everybody's saying the same thing.
Yeah, I was taking out French. I got extra help with English in my school, and it was very helpful.
Isn't it? Thank you.
We've just got somebody at the back there.
Thanks.
Yeah, my son's actually 4.5 now. He's been in mainstream school for a 1.5 years. Because he was statemented, he's had a TA to work every time for the full 12 hours he's in school, which has been very beneficial.
but the school's actually been very good in that, because he's, although the school have actually provided the TA for him, they're not set up to work with the child with learning disabilities, but because of his statement, he can actually go to a school with a special teaching facility now within the county, but you can actually be very careful if you are going to go for a statement, make sure that your views are taken into account. That's very important, because although they need the professional input as well, your views will actually make up more of the input that you want for your child. So I think it's just something very important that if you are going to go for a statement, which I recommend you do, that you as the parent or carer put your views forward in either by filling in the form or writing a letter, which you can do.
Great, thanks. So I mean, generally actually shows a few people have had experiences of statements actually being very useful. That's something I've also seen. I see people who are coming up to what we call transition, so people aged around 16 coming from sort of paediatric services into adult services, and quite a few people are only just at that stage being diagnosed and it being realised that actually myotonic dystrophy has been affecting their schooling. But even getting statements at that late stage in schooling can make an awful lot of difference. So on to something different, but still perhaps in a sort of child realm, but I think this actually could is relevant to any age to some extent. So this one says, what kinds of intervention, if any, can improve a slurred speech? For instance, 3-year-old with good vocabulary but stammering, repeating words. Is it acquired? Is it common? Is it best ignored? It's a slightly difficult question in a way, but perhaps easier to look at with children. Speech and language therapists can actually do quite a lot of training and coaching to help children who've got problems with their speech. And often actually is very useful at an early age to see if a child's starting to have problems. For adults with myotonic dystrophy, one of the things that we do struggle with actually often is treatment specifically aimed at trying to help improving the slurring of speech. That can be quite difficult, but the speech and language therapist can help to some extent. Often it is quite simple measures like slowing down rate of speech, paying attention to certain parts of speech, but that sort of practice can help. Sometimes there's a bit of component from actual myotonia causing problems of speech as well. So in short, there is some help, but perhaps in adults it wouldn't be quite so, we wouldn't be able to get quite so far as we might hope to. Again, I don't know if anybody wants to add to that.
Sometimes you've got to be careful. The speech can sometimes be affected by accumulation of saliva and food at the back of the throat. As opposed to, that's more of a problem with swallowing as opposed to articulation, which we've described here. As Margaret said, sometimes mixility, I don't know whether, I've got a couple of patients who swear that their speech is less slurred, but these are adults, not children, using mixility, which treats the myotonia, the stiffness, because the stiffness can certainly affect the tongue, as David Hilton-Jones mentioned earlier. Much experience using mixility for swallowing and speech?
A bit like you, my experience with it is that when I've been using it for somebody else who has had problems with severe myotonia elsewhere, that actually it's improved their speech. But it's also very well known that myotonia of the tongue, if you think about what you're doing when you're speaking, your tongue has got a fantastic number of little tiny muscles all moving very quickly in it. If you've got myotonia of your tongue, it can't do it. It's just not physically possible for it to relax quickly enough, and that's why the speech tends to be slurred. I mean, joking apart, there's a part of me that's a bit tempted when we have these sorts of question and answer sessions to say to everybody here, if you've got myotonic dystrophy, if you haven't actually slowed down when you pick the microphone up, and when you're nervous, we as well will tend to speak more quickly. So you need to make even more of an effort to slow down when you're speaking so people can understand you. Thank you.
Now we've got another question for Chris to read out.
Professor David said that this would be a good one for me. Is there a link between myotonic dystrophy and dementia? I often use the word dementia in the context of myotonic dystrophy, and it's difficult because patients with myotonic dystrophy don't get dementia in the sense that we all know dementia, so Alzheimer's disease. So that's the good news. I guess the other side of it, and I guess the neurological community is split on this, is whether the progressive loss of brain cells occurs in small areas of the brain which can cause neurological problems in myotonic dystrophy. My own feeling is that does happen, and those of you who came, I think it was Peterborough, Nottingham, I spoke a few years ago and got one of the audience to do this, what's called a Stroop test. Do you remember that, Margaret? I think it does. For instance, the daytime sleepiness, that is, it's not a dementia, but it's a small area of loss of brain cells in the brain causing you to be sleepy. There is evidence, if you look at patients' brains under the microscopes, although you'll be glad to hear not many patients' brains have been looked at under the microscope, but there is evidence that there is accumulation of proteins which are similar to known dementias, and there's other studies using MRI scans, and the studies that Margaret and David are going to do with Paul Madison, part of that trial is to, you've got MRI and neuropsychometry. So the short answer is it's not dementia in the well-known dementia sense, but almost certainly there is loss of brain cells, particularly at the front of the brain, but the side of the brain, deep within the brain, little focal areas that cause problems with memory and thinking and planning movements and coordinating movements. The balance problems almost certainly is related to some of that as well. I suspect Margaret may have something to say as well.
I don't have that much to add to it. I suppose it is very much more about those sort of problems to do with planning and organising and doing several things at once. And that is what we normally term dementia. Really, it isn't that. A lot of what people would talk about when they talk about dementia is much more to do with memory, which we don't see as a huge problem in myotonic dystrophy. But it's more around a lot of those other sort of day-to-day things that the brain does that we often don't actually think about.
I should say that you've got to be very careful when somebody has cognitive problems that you don't assume that it's due to the disease. The commonest cause of memory problems that I see as a general neurologist is actually not because of dementia. It's because of depression, low mood, too many anxieties, poor sleep, and occasionally too much booze and other things. And very rarely vitamin problems and things like this, but actually low mood, I would have to say, is probably the commonest treatable form of thinking and memory problems that I see as a neurologist, more common than Alzheimer's disease.
So, would you recommend an antidepressant in that case?
The question was, would I therefore recommend an antidepressant? I would, yes. The caveat to that is that some of the antidepressants can affect the heart and cause the heart to go too quickly, and you just have to be slightly careful with which antidepressant you choose. But as far as I'm concerned, there's absolutely no reason that antidepressants shouldn't be used cautiously in myotonic dystrophy if need be, and that can improve cognition in its own right. I don't know whether Margaret's got.
Yeah, although what I'd always want to add, if I'm recommending an antidepressant in anybody, I'd also want to be looking at them having some help from a psychologist, or at least from a counsellor. Because the antidepressant can do a lot to actually help the brain chemicals to, if you like, right themselves, but to actually alter things and help long term, and to stop it recurring, and to look at some of the root problems of somebody's depression, often is actually very useful to see a psychologist and look at some of those sort of what you would think of as sort of talking therapies, as you say, to actually help. And that's because really the way people often think that physical things and things to do with your brain are very separate, but they're not, and they both interact quite closely. So actually talking through things and looking at different ways of thinking about things, and looking at different, and trying to perhaps change the way we look at things, perhaps to a more positive light and a negative light, and developing those habits of thought can make a huge difference to conditions such as depression and anxiety.
I mean, the part of the optimistic study, I don't know whether Libby wants to mention anything here, is to use cognitive behavioural therapy, and presumably part of that maybe to tackle mood problems, Libby?
You put me on the spot a lot here, Chris. Yeah, I suppose it is. It's to improve quality of life and reduce fatigue through non-drug methods. So it's a combination of cognitive behavioural therapy and improving exercise or physical activity to try and change mood, I suppose.
My son is drinking an awful lot of energy drinks. They're not recommended to the general population, but can I stress because it is my son that I give advice
The danger of drinking too many energy drinks. My son drinks a lot of them. Whether it's the same effect as modafinil, I don't know, or more dangerous or what.
I think the thing with something like modafinil, at least you've got a very controlled dose and you know exactly what you're taking. If you're taking energy drinks, they often contain pretty high levels of caffeine, and they can have some quite serious effects, especially for myotonic dystrophy. If you're looking at some of the heart problems people might get, they're probably best avoided if possible.